Imagine going to the doctor with like debilitating, completely sleep-destroying physical pain.
Oh, it's awful.
Right. And you finally get the courage to explain what's happening to you, and they just look you in the eye and say, well, that's just part of getting older, or,
Yeah.
it's just menopause.
Yeah.
For thousands of women seeking medical care right now, I mean, this isn't some hypothetical scenario. It's a deeply frustrating daily reality.
It really is. It's a phenomenon we might call the medicalization of suffering.
Mm.
There is this pervasive underlying assumption in society that certain stages of a woman's life are, simply supposed to hurt.
Right, like you're just supposed to grin and bear it.
Exactly.
Mhm.
And when a medical professional operates on that assumption, it completely shuts down any real diagnostic curiosity.
It really does. You get handed like a generic leaflet on vaginal dryness, maybe a sample of moisturizer, and you're just sent on your way.
Yep.
Meanwhile, underneath the surface, something much, much more destructive is actively happening.
Oh, absolutely.
So welcome to this deep dive. Today's mission is to unpack a highly specific, crucial, and frankly, really misunderstood medical intersection.
It's a vital one to talk about.
We are asking, what is the exact impact of low estrogen levels during menopause on the severity of lichen sclerosus symptoms?
It is a critical question because when these two conditions overlap, and they do overlap frequently, the diagnostic waters get incredibly murky.
Because they look so similar.
Yeah, the symptoms mask each other, they amplify each other, and if someone isn't looking closely at the underlying mechanisms, well, the long-term consequences for the patient are severe.
Which is terrifying. So to figure this out, we are synthesizing a stack of clinical guidelines, dermatology reviews, and patient advocacy resources.
Very comprehensive.
Yeah, we're pulling directly from the British Menopause Society, the American Family Physician Journal, and the Lichen Sclerosus Support Network. Okay, let's unpack this, because before we can even bring lichen sclerosus into the picture, we have to establish the baseline. We need to understand what is physically happening to the body when estrogen drops during menopause. Like, what is estrogen actually doing for the vulva on a day-to-day basis?
To put it simply, estrogen is the primary architect of healthy genital skin.
The architect.
Yeah, think of it as the ultimate project manager for that specific tissue. It maintains the thickness of the epidermis, the outer layer of skin.
Okay.
It dictates the surface lipid content, meaning it keeps those natural protective oils flowing. And crucially, it ensures there is a robust collagen network in the dermis underneath.
So it's basically building the scaffolding.
Exactly. Scaffolding that keeps everything hydrated, elastic, and resilient.
So when menopause hits and estrogen levels plummet, that project manager basically just walks off the job.
Clocked out. Gone.
And the architecture loses its structural support.
Precisely. And in modern medicine, the term for this resulting structural collapse is genitourinary syndrome of menopause, or GSM.
GSM. Got it.
Historically, you might have heard it called vaginal atrophy, but GSM is the current term. When the estrogen goes away, the vulva and the vagina undergo profound, highly visible physical changes.
Like what?
Well, the tissue becomes noticeably pale, mainly because the blood flow decreases significantly. It becomes incredibly thin, and it becomes severely dry.
There is a detail about this process that absolutely blew my mind when I was reading through the clinical guidelines.
Oh, about the cells.
Yes. It has to do with the cellular turnover rate. Can you explain how fast these cells are actually replacing themselves when estrogen is present?
It is a remarkable physiological mechanism, honestly. In a healthy, well-estrogenized vagina, the superficial cells are the ones right on the very surface of the tissue.
Right.
They turn over and completely replace themselves every 4 hours.
Every 4 hours. That is wildly fast for cellular regeneration. I mean, think about that.
It is fast, and it has to be, because it serves a vital microscopic purpose.
Okay, what is it?
When those surface cells turn over and shed into the vaginal canal, they release a complex sugar called glycogen.
And that sugar isn't just waste, right? It's food.
Exactly. That glycogen acts as the primary food source for healthy lactobacilli.
Those are the good bacteria.
Yep, the dominant good bacteria in the vaginal microbiome.
Yeah.
So the lactobacilli consume the glycogen, and as they metabolize it, they essentially sweat out lactic acid.
Sweat out acid. That paints a picture.
It does, but that constant production of lactic acid is what maintains a low acidic pH in the vagina.
Which is a good thing.
A very good thing. That acid is a shield. It protects the entire environment from outside infections and overgrowth of bad bacteria.
So it's like an entire self-sustaining microscopic factory down there.
Precisely.
Estrogen drives the cell turnover, the cells feed the bacteria, and the bacteria produce the acid that keeps the whole system safe.
That is exactly how it works. Now imagine what happens when estrogen drops during menopause.
The factory shuts down.
Entirely. That rapid 4-hour cell turnover just grinds to a halt. The cells stop shedding. Because they stop shedding, the glycogen disappears.
And without the glycogen, the good bacteria starve.
They starve to death. And without the bacteria, the lactic acid is gone and the pH rises. Suddenly, you are left with an environment that is fundamentally compromised.
Wow.
The tissue becomes highly prone to microtrauma, to tearing from just basic friction and to chronic infection.
You know, the best way I can picture this physical change is to think of a kitchen sponge.
Okay, I like that.
Right, so a healthy estrogen-rich vulva is like a resilient, waterlogged sponge. You can twist it, you can squeeze it, you can scrub a counter with it, and it just bounces right back to its original shape.
Yeah, have that bounce.
But the menopausal vulva suffering from GSM is like a sponge that has been left sitting on the counter to dry out for 2 weeks in the sun.
Oh, completely brittle.
Exactly. It shrinks, and if you try to bend it or put any friction on it at all, it doesn't bounce back. It just cracks and tears apart.
That's a perfect analogy. And that loss of elasticity is where the real vulnerability begins.
Yeah.
The tissue has literally lost its ability to absorb and withstand everyday physical stress.
It's a broken barrier,
It's a completely compromised barrier.
which perfectly sets the stage for the intruder.
Yes, it does.
Now that we have established that the vulva is in this fragile, dried out, brittle state due to menopause, we need to bring in the specific condition that thrives in this exact vulnerability, lichen sclerosus.
Let's get into it.
So let's break this down. What exactly are we dealing with when we talk about LS?
Lichen sclerosus, often abbreviated as LS, is a chronic autoimmune inflammatory skin condition.
Autoimmune.
Yes, and I want to stress this right up front because it is the source of so much confusion. It is not an infection.
That's a huge distinction.
It's everything. It is an autoimmune disease. What is happening is that the body's immune system is essentially misidentifying a specific protein located in the basement membrane of the skin.
Wait, let's pause there for a second. Explain what the basement membrane is for us.
Of course. So think of the skin as having layers. You have the outer layer, the epidermis, and the deeper layer, the dermis.
Okay.
The basement membrane is essentially the ultra-thin layer of biological glue, or like Velcro, that holds those two layers together.
Oh, okay.
In lichen sclerosus, the immune system decides that the protein in this glue is a foreign invader. So it mounts a massive, localized inflammatory attack against it, trying to destroy it.
So it's attacking its own glue.
Exactly. And this attack primarily targets the vulva and quite often the perianal region too, so the skin around the anus as well.
And what does that localized autoimmune attack actually feel like for the person experiencing it? Like, what are the day-to-day symptoms?
The hallmark symptom, the one that really drives patients to seek help, is intense, relentless itching.
Just nonstop.
Nonstop. And patients universally report that this itch is significantly worse at night. It is not uncommon for the itching to disrupt sleep entirely.
Which leads to chronic exhaustion.
Chronic exhaustion and a huge psychological toll. I mean, it's maddening.
Yeah.
Alongside the itch, there is severe burning, soreness, and painful sex, which is clinically known as dyspareunia.
And visually, if a doctor is doing an exam, what are they actually looking for?
Visually, LS presents as porcelain white, parchment-like patches on the skin.
White patches.
Yes. And because the disease frequently affects both the vulva and the skin surrounding the anus, these white plaques often connect.
Forming a shape.
Yeah, they form a very distinct figure-of-8 pattern. The skin itself looks waxy, it gets crinkled, kind of like tissue paper, and it appears severely thinned out.
Wait, I have to push back here for a second because this sounds like a massive red flag for misdiagnosis.
Oh, you have no idea.
I mean, if a woman goes to her doctor complaining of intense vaginal itching, burning, and white patches, isn't a doctor just going to immediately assume it's a severe yeast infection, like chronic thrush?
Yes.
Or worse, maybe a sexually transmitted disease?
You've hit on a massive systemic problem in women's healthcare. Yes, it is constantly misdiagnosed as thrush.
Constantly.
Constantly. Women will spend months, sometimes literally years, trapped in a cycle of buying over-the-counter antifungal creams that do absolutely nothing.
Because it's not a fungus?
Right. Or they're getting prescribed endless rounds of antibiotics that actually wipe out whatever good bacteria they have left and make the underlying inflammation worse.
That has to be incredibly isolating. You're doing everything the doctor says, and you're still in agony every single night.
It is devastating. And to your second point, if a doctor isn't specifically trained to recognize the visual signs of LS, they might suspect a sexually transmitted disease.
Which is a whole other layer of trauma.
Exactly. It causes a tremendous amount of unnecessary anxiety and relationship distress. So we have to emphasize this loudly and clearly. Lichen sclerosus is not contagious.
Okay.
You cannot catch it from someone. It is
Yeah.
not sexually transmitted, and it is not a fungal or bacterial infection.
It's your own immune system attacking the glue in your skin.
Exactly. In fact, because it's autoimmune, it is frequently linked to other autoimmune diseases.
Oh, really? Like what?
The research shows that up to a third of women with vulvar LS have another autoimmune condition somewhere else in their body.
A third! That's a huge overlap.
It is. The most common overlaps are autoimmune thyroid issues, or vitiligo, which is a condition where the immune system attacks the pigment-producing cells of the skin.
Okay, so this brings us to the absolute core of our deep dive. We now have our two major factors on the table. We have the brittle, dried out, cracked sponge of genitourinary syndrome of menopause, and we have the relentless autoimmune fire of lichen sclerosus.
The collision.
Exactly. What happens when these two forces collide in the same body?
To really understand the collision, we have to look at a fascinating epidemiological clue.
Okay,
When you track who gets lichen sclerosus, you see what we call a bimodal peak.
meaning two peaks.
Yes, that means there are two distinct, separate times in a female's life when she is most likely to develop the disease or see a massive flare-up.
And when are they?
Those two times are prepubescent girls, so before they start menstruating, and postmenopausal women.
Wow. Both of which are life stages characterized by very, very low estrogen levels.
What's fascinating here is that the low estrogen does not cause the autoimmune disease itself.
It doesn't cause it. Okay.
Right. Lichen sclerosus is fundamentally driven by immune dysregulation, not just by hormones.
Yeah.
You can't just catch LS because your estrogen dropped.
Right, that makes sense.
However, the menopausal drop in estrogen acts as a massive, devastating amplifier. It strips the vulva of all its natural structural defenses.
Right, because the sponge is dried out,
Yeah.
the barrier is totally compromised.
Yes, that thinned, fragile, GSM-affected tissue is simply no longer capable of withstanding the intense inflammatory attack of the immune system. The structural integrity is already gone.
So it just wreaks havoc.
Exactly. Because of this, you might have a woman who had, very mild, easily manageable lichen sclerosus in her 30s. Maybe she just used a little cream once in a while and it was totally fine.
Okay.
But the moment she hits menopause and her estrogen plummets, that mild condition can turn into a sudden, severe, completely debilitating flare-up.
It makes me think of a house that has a termite infestation.
Oh, I like where this is going.
Right. The termites represent lichen sclerosus. They are the active, aggressive attackers chewing away at the structure. Now, if the house has solid, thick, healthy wood, the termites will still do damage, but it will take a long time to show.
You have some time to deal with it.
Exactly, you have time. But if the house's wood is already rotting and crumbling from severe long-term water damage, and that's our low estrogen, the termites are going to tear through it in no time at all.
Instantly.
Right. The structural collapse of the house is going to happen incredibly fast compared to healthy wood.
And that structural collapse is exactly what we see in the clinic. The low estrogen has rotted away the defenses, allowing the autoimmune termites to just run rampant.
Which is terrifying.
It is.
Yeah.
And this leads us to the most dangerous part of this intersection. Because the symptoms of low estrogen and the symptoms of LS amplify each other, they create a very dangerous diagnostic trap.
Because the symptoms overlap almost perfectly.
Yes, they do.
Both GSM and LS cause severe dryness, intense burning, and painful sex. So a woman in her 50s finally goes to the doctor. She bravely describes these really intimate symptoms, and the doctor just looks at her age, hears the symptoms, and says,
It's just menopause.
just menopause.
The doctor prescribes a standard vaginal estrogen cream, assumes the problem is entirely solved, and just sends her home.
But the estrogen only fixes the water damage. It doesn't kill the termites.
Exactly.
So what are the actual stakes here? Like, what happens to the patient if the doctor misses the LS diagnosis and only treats the estrogen drop?
The stakes are incredibly high. While estrogen treats the dryness, it does absolutely nothing to stop the immune system from attacking that basement membrane.
So the attack continues.
Unchecked. And if left untreated, that chronic inflammation progresses to permanent anatomical destruction. This is where we need to explain what it means when we say LS is a fibrotic disease.
Right. Break down fibrotic for us. What does that mean?
When the immune system constantly attacks the tissue, the body obviously tries to heal it. But instead of laying down healthy, stretchy, elastic tissue, it lays down rigid scar tissue.
Okay.
That scarring process is called fibrosis. Imagine replacing a stretchy rubber band with a hard piece of twine.
Oh, that sounds awful.
It is. The tissue loses all ability to stretch or function normally. And the clinical guidelines are very clear on how devastating this is. The chronic inflammation essentially melts the tissues together.
Melts them together, and that leads to some pretty intense structural changes, right?
Extremely intense. You see fusion of the labia, where the inner lips literally scar and fuse together, basically closing over.
Wow.
You see the complete absorption of the labia minora into the labia majora. They just flatten out and disappear. And the clitoris can become completely buried under thick, fibrotic, scarred tissue.
Which is called clitoral phimosis, right? That sounds absolutely agonizing.
It is. Clitoral phimosis traps the clitoris under a hood of scar tissue, which causes severe, constant pain, chronic trapped infections, and a complete loss of sexual sensation.
That's horrifying.
And it gets worse. Furthermore, the opening of the vagina can narrow and scar over so much that penetration, or even something as simple as passing urine, becomes excruciating.
And beyond the horrific structural damage and the daily pain, there is a much darker risk lurking if this inflammation goes untreated, isn't there?
Yes, there is. The ultimate risk of untreated, unmanaged lichen sclerosus is that the chronic, relentless inflammation can eventually trigger cellular mutations.
Cancer.
Yes. Women with unmanaged LS carry a roughly 5% lifetime risk of developing vulvar squamous cell carcinoma, which is vulvar cancer.
Okay, if you are listening to this right now and feeling a bit panicked, maybe you're recognizing some of these symptoms in yourself, I want to ask directly on your behalf, how do you tell the difference?
This is the most important question you can ask.
Right. If you have itching, dryness, and painful sex, how can you know if it's just menopause or if the autoimmune termites of lichen sclerosus are in the house?
The key distinction lies in the visual and structural changes. GSM, the atrophy from menopause, causes generalized thinning, dryness, and a pale appearance to the tissue.
Okay, pale and thin.
But GSM does not cause distinct porcelain white plaques. And GSM does not cause architectural scarring.
So menopause won't change your actual anatomy.
Exactly. Menopause alone will not fuse your skin together or bury your clitoris. If you are seeing distinct white patches, or if you notice your anatomy is actually changing shape, fusing, or disappearing, that is not just menopause.
That's a huge red flag.
It is. You need to bypass the standard advice and see a specialist, usually a gynecologist or a dermatologist, for a clinical diagnosis or a biopsy to confirm LS.
That is a very clear, actionable distinction. White patches and structural changes mean you demand a specialist.
Oh.
So let's look at the best case scenario. The doctor gets it right. They recognize that you are trapped in this collision. You have the autoimmune attack of LS and the hormonal depletion of menopause.
Right.
How do you untangle that knot? How do you treat this compounded issue safely and effectively?
Well, you have to treat both conditions simultaneously, but you have to use entirely different tools.
Okay.
The absolute first-line treatment for lichen sclerosus, the only thing proven to stop the autoimmune attack, halt the scarring, and prevent that 5% cancer risk, is an ultra-potent topical corticosteroid.
Ultra-potent.
Yes. The global gold standard is an ointment called clobetasol propionate 0.05%.
And this isn't just something you dab on when you feel a little itchy, right? The regimen is pretty intense.
It requires extreme discipline, especially at the beginning. The clinical guidelines recommend using what's called a fingertip unit, which equates to about a pea-sized blob of ointment.
Okay, a pea-sized blob.
You massage that specifically into the affected areas once a day, every single night, for a full month.
A full month, every night.
Yep. After that month, if the inflammation is cooling down, you taper. You drop to every other day for another month, and eventually you land on a maintenance dose of twice a week.
And is that forever?
For most women, yes, that maintenance dose is lifelong.
I can easily imagine someone hearing the phrase ultra-potent steroid on my genitals and feeling a massive wave of anxiety.
Oh, absolutely.
Because we're constantly told that steroids thin the skin, which seems like the exact opposite of what you want for tissue that is already thin from menopause.
What you're describing is a very well-documented phenomenon called steroid phobia. And it is one of the biggest barriers to healing.
Really?
It prevents so many women from getting better. When you go to the pharmacy and open a tube of clobetasol, the manufacturer's leaflet inside will explicitly warn you, often in bold red letters, do not use on genitals.
Which is absolutely terrifying if your doctor just handed you a prescription and told you to put it exactly there.
Completely terrifying. But you have to understand the context of that warning. That generic warning is designed for a normal, healthy person who might be tempted to use a strong steroid for a mild rash.
Okay.
Normal genital skin is thin and absorbs medication very quickly, but a patient with lichen sclerosus does not have normal genital skin.
Because it's fibrotic.
Exactly.
Yeah.
LS is a fibrotic disease. The skin is abnormally thickened with deep microscopic inflammation and scar tissue in ways we can't always see on the surface.
Right.
For LS, this ultra-potent steroid is perfectly safe. It is absolutely necessary to break through that fibrosis. Used correctly, it will actually return the skin to a normal, healthy texture.
So it won't thin it out.
It will not thin it out dangerously because it's fighting against abnormal thickening.
Okay, so the steroid puts out the autoimmune fire and stops the scarring. But what about the estrogen? We established the sponge is still dried out from menopause.
Right, the GSM is still there.
Here's where it gets really interesting. Topical vaginal estrogen is the perfect adjunct therapy here, isn't it?
It absolutely is. Topical estrogen will never cure lichen sclerosus on its own. But if a postmenopausal woman is rigorously using her steroids to fight the autoimmune side, adding topical estrogen treats the underlying GSM.
It fixes the sponge.
It fixes the sponge. The estrogen plumps up that background tissue. It restores the elasticity. It brings back the blood flow. It gets that 4-hour cellular turnover moving again.
And brings back the good bacteria.
Yes. And it essentially makes the steroids' job so much easier
Right.
because the tissue has its resilience back.
It's the ultimate two-pronged attack. To fix the vulva in this specific scenario, you need both tools.
You do.
You need a fire extinguisher, which is the ultra-potent steroid, to put out the autoimmunifier of the LS. And you need fertilizer, which is the estrogen, to help the damaged, dried-out garden grow back and stay healthy.
Yes, and if you only use the fire extinguisher, the fire's put out, but you are still left with a dry, brittle garden that is easily damaged and painful to live in.
Right.
Conversely, if you only use the fertilizer, which is exactly what happens when doctors casually dismiss this as just menopause, you are feeding a garden that is actively burning down.
That's such a powerful way to look at it. You need both to restore the ecosystem.
You absolutely need both.
Wow. Let's summarize where we've landed today because this is incredibly empowering information.
It really is.
Our core takeaway is this. Low estrogen during menopause does not create lichen sclerosus, but it acts as a massive, devastating amplifier for the disease by stripping away the vulva's natural defenses, hydration, and resilience.
Spot on.
Because the symptoms of dryness and pain overlap so closely, thousands of women fall into the misdiagnosis trap where they are told it's just menopause. Missing the LS diagnosis leads to permanent anatomical scarring and a very real increased risk of cancer.
Which is exactly why a dual diagnosis requires a dual treatment plan. You must use the ultra-potent steroids to stop the autoimmune inflammation, and you must use the topical estrogen to restore the tissue's underlying cellular health.
Leaving out either side leaves you vulnerable.
Leaving out either side of that equation leaves the patient deeply vulnerable.
It really forces a total reframing of how we think about women's pain. It's rarely binary. It's not just aging or an infection. It's a complex, interactive ecosystem.
It is.
And to leave you with one final provocative thought to mull over, there was a fascinating detail buried in the dermatology sources regarding something called the Koebner response.
Ah, yes, the Koebner response. It is a very well-documented phenomenon in dermatology.
What is it exactly?
It refers to situations where a mechanical friction or mild physical trauma to the skin actually triggers or worsens an autoimmune response, literally drawing the disease to that exact spot of trauma.
Right. So if we know that low estrogen makes the skin incredibly fragile, thin, and highly prone to micro-tearing from everyday activities.
Like just walking around.
Just walking around the block, riding a bicycle, wiping with toilet paper, or sitting in tight jeans. Could the simple mechanical trauma of existing with low estrogen be the very trigger that flips the autoimmune switch for lichen sclerosus in susceptible women?
It is a profound paradigm-shifting question. It suggests that the menopausal hormonal drop doesn't just make an existing disease worse, but the harsh physical reality of living with that untreated friction might actually be the catalyst that wakes the autoimmune disease up in the first place.
It's a compelling reminder of how deeply interconnected our hormones, our immune system, and our physical environment truly are.
Couldn't agree more.
The diagnostic landscape might be murky, and the medical system might default to dismissing us, but when we actually investigate the mechanisms of pain instead of ignoring them, the picture finally becomes clear. Keep asking questions, keep pushing for answers, and we'll catch you on the next deep dive.